Hello everyone. Today's topic for discussion is amblyopia. Before I step into amblyopia, you should know what are the developmental milestones, especially the visual developmental milestones. And this tabular column will depict exactly what is needed. See, from 0 to 2 months of age, the child mainly has a pupillary reflex and most of them will have a squint. It will be an erratic movement. It can be an exodeviation, it can be an esodeviation, but they are quite common. There's nothing to worry about. Over the time, as a month proceeds, when it reaches around 2 to 6 months of age, the child can fixate centrally and it will follow the object and it can start identifying the mother's faces. And here is where the binocular smooth pursuit movements will start developing and they will have orthotropia. So by 6 months of age, the child should be able to fixate. Any deviations or any abnormality in fixation even at the age of 6 years is considered to be an abnormal. Above 6 years till 2 years, child will have a central steady fixation and it will follow the movement of it with an orthotropia. Above 3 to 5 years, you can check the vision by using a Snellen's picture charts or an alphabetical charts. Now coming to certain important milestones in this, that is till 3 months of the age the visual acuity will develop very rapidly and it is a very critical period for your visual development. Especially from 6 months to 6 years, whatever happen in this age group will give a dense amblyopia in the later period. To remember, the fusion usually develops by 1.5 to 2 months and the stereopsis you will get around 3 to 6 months. The other important milestones for this include central fixation and acute smooth pursuit movement, as I said, till 3 months of age. And poor fixation at 6 months of age is always pathological and you have to evaluate the child. Now, coming to any abnormalities in these development can lead to a different conditions. It can cause suppression and later go for amblyopia. Like if the child has a strabismus or any blurred image of because of any corneal cause or a lenticular cause or a retinal cause, it can cause blurring of the image or dissimilarity in the image which is formed on the retina. This dissimilarity between the retinal image, if it is more, then it cannot be fused. Usually the immature child, it will start adapting by inhibiting the cortical activity from these blurred image and it will take whatever is the sharp image and thus the eye with a blurred image will go for cortical suppression. If the image is falling in this area which is not pursued, that will give you a suppression scotoma and later on this suppressed eye can even go for amblyopia. Now coming to amblyopia per se, this is one of the common cause for the low vision in the children. Most of the time it will go unnoticed. Amblyopia, the term means dull vision. It's a poor vision caused because of abnormal visual development secondary to abnormal visual stimulus. This is also termed as functional amblyopia or amblyopia ex anopsia. Anything that happens from 6 months to 6 years of age has a high chances of going into amblyopia. There are studies that says that even beyond 6 years there are chances of developing amblyopia. The earlier the onset of amblyopia, the denser it will be and the more amount of visual deficits. Clinically, how do you diagnose amblyopia? Whenever there is at least 2 Snellen's line difference between the visual acuity between two eyes, then we call it as amblyopia. Amblyopia can be an organic amblyopia or a functional amblyopia. We call it as organic whenever the poor vision is because of any structural abnormalities either in the eye or in the brain, independent of the sensory output. Means to say, the sensory stimulus, whatever the light stimulus is coming, is normal and it is reaching the eye. Because there is an abnormality either in the eye or in the brain, it is causing a poor vision. Like in cases of optic atrophy, macular cause, or any central causes that is damaging your brain. Less organic amblyopia. What is functional amblyopia? Functional amblyopia is when there is a poor vision without any organic cause. That means to say the eye and the brain are normal, but whatever the stimulus that is reaching the eye is being occluded, or there is a defect in the stimulus that is coming. So, based on these things, we classify amblyopia into different categories. So, the main pathology that exists in amblyopia is either a visual deprivation or a light deprivation, or they'll have an abnormal binocular interaction. To make it simpler, I've made a mnemonic for amblyopia different types, that is AIMS T, means to say A is anisometropic amblyopia, I isometropic amblyopia, M meridional amblyopia, S strabismic amblyopia, T toxic amblyopia. Anisometropic amblyopia when one eye is having a high refractive power and the other eye is not. Hyperopes are more prone for amblyopia than myopes. Isometropic amblyopia, bilateral amblyopia in a children with an uncorrected bilateral refractive errors. In this, hyperopes are more prone for amblyopia compared to myopes. Meridional amblyopia, this is in regarding to astigmatism. This can cause selective amblyopia for selective meridional region. What does stimulus deprivation amblyopia means? It is also called as amblyopia ex anopsia, when eye is totally excluded from seeing the light. That is because of the blockage of the light rays which is coming into your eyes, like in case of cataract, complete ptosis, any corneal opacities. And the one more is strabismic amblyopia, whenever there is a prolonged uniocular suppression because of the squint. Being this strabismic amblyopia is the most common form of amblyopia. Toxic amblyopia, this occurs because of various agents like ethyl alcohol, methyl alcohol, ethambutol. These are all drug induced. How do you identify? When you check the visual acuity using a Snellen's chart, they will have a visual acuity difference of 2 Snellen's line between the two eyes. And there's something called crowding phenomena, which is a characteristic of amblyopia, where the person will not be able to read whenever the whole of the Snellen's chart is being displayed. If you make it as a single line or a single letter, he'll be able to read it better. Diagnose amblyopia. The first thing is by doing visual acuity testing, as I said, and you also document for the crowding phenomena. Then comes your fixation test. There's something called monoocular fixation, and you check whether the eye is fixating through the fovea or it is eccentric. How do you test the central fixation? The smooth pursutic movement indicate the child is having a good foveal fixation and at least a vision of 20 by 100 or better, and this should usually be seen above 3 years of age. Eccentric fixation, a patient is weaving from extrafoveal area of the retina, will have a poor pursuit movement and will not be able to accurately trace the moving object. And there is something called visuoscope. Here, with that instrument, you project the light onto the parafoveal area and you ask the patient to see the light. Whenever he is using the fovea as a fixation point, he will be able to fixate that light onto the fovea. But if he is fixating through eccentric area, you can see the light image is falling onto the parafoveal area, or the patient will have a difficulty in finding the image. The more is the eccentricity of the fixation, the denser the amblyopia. If this is the retina, and then if this is the fovea, this can be in foveal fixation or somewhere in the extrafoveal region. The farther is the fixation point, the denser will be the amblyopia. And next comes your fixation preference test, which is very useful in preverbal strabismic children. A strong fixation preference will indicate amblyopia in the other eye. For suppose the patient prefers to fixate through the right eye, in the sense the left eye has gone for the amblyopia. Whenever there is a equal vision in the both eye, or if the patient is fixating alternatively between the two eyes, there are less chances that they have a amblyopia. And how do you clinically test it? There is something called vertical prism test. Here you place a either 10 diopter or 15 diopter prism base up or base down in front of one eye. Imagine this is the right eye and this is the left eye. And if the right eye is having a amblyopia and left eye is normal, whenever you place a prism in front of the right eye, the left eye remains at same position, because you are using left eye for the fixation, and the right eye will not move whenever there is a prism in front of the right eye. Same thing whenever you place a prism in front of the left eye, which is a fixating eye, the eye will move up, both of it will move up. Means to say the left eye is a fixating eye and it is a dominant eye, and the other eye has gone for suppression. Till now you want to know how to diagnose the amblyopia, what is amblyopia, what are the different types of amblyopia. In the next part we'll cover how to manage amblyopia. Thank you.